Hello, and welcome to Shelf Life from the Virginia Festival of the Book. I'm Jane Kulo, Director of the Virginia Center for the Book, a program of Virginia Humanities. Thank you for joining us. A couple of notes before I hand the program over to our speakers. Please share your questions using the Q&A tab on Zoom. This event has optional closed captioning, which you can turn on and customize at any time with the closed captions tab at the bottom of your window. If you haven't already read today's book, we hope you will. For details about how to buy it from a local bookseller or check out a copy from your library, visit vabook.org, where you can also explore the schedule of upcoming programs and watch past events. While you're there, please consider making a donation to support the festival's ongoing work at vabook.org/give. Now, I'm pleased to introduce today's speakers. Daisy Hernandez, author of The Kissing Bug, a true story of a family, an insect, and a nation's neglect of a deadly disease, is a former reporter for the New York Times and has been writing about the intersections of race, immigration, class, and sexuality for almost 2 decades. She is an associate professor at Miami University in Ohio. Dr. Rachel Marcus is the medical director of the Latin American Society of Chagas, a nonprofit based in the metropolitan Washington, D.C. area that provides free screening and treatment for Chagas disease, along with basic cardiac testing. And our moderator is Leah Esslinger, who is a freelance writer and researcher in the Charlottesville area and is currently the communications assistant at Virginia Humanities. With a master's in anthropological linguistics from UVA, Leah's research interests include language, power, and identity, and she writes murder mysteries in her spare time. Daisy, Rachel, and Leah, thank you for joining us for Shelf Life. Over to you, Leah.
Thanks, Jane. I want to just thank Daisy and Rachel for joining us, and everybody at home or wherever you are. I do want to remind you that we are accepting questions, so please do feel free to add them whenever you think of them. And also, today is National Chagas Day. And so here we are talking about Chagas. So just to get us started, maybe you can, both of you or one of you can tell us, what is Chagas?
So Chagas disease is a neglected disease of poverty or neglected tropical disease. It's a parasitic infection that is associated with someone having lived in rural poverty in Latin America, and it can cause both an acute illness, which tends to be pretty mild, but then over the next decades can turn into a truly catastrophic infection of the heart that can cause people to have strokes or sudden cardiac death, heart rhythm problems, or very severe heart failure that can even require heart transplantation.
Okay, thank you. And so how did you, I'd love to hear from both of you, how did you first become aware of it?
Daisy, why don't you start?
And I would love to hear your answer too. For me, my auntie was diagnosed with Chagas disease when I was very young. I was about 5 or 6, and she was actually, she grew up in Colombia in South America, and that's where she first started to get sick. My mother and other aunties were living here in the US and were able to bring her, and sort of a very fortuitous set of events that I write about in The Kissing Bug. She was able to get into a clinic for patients without health insurance at the time. She was on a tourist visa as well. Ended up overstaying that and to get medical care and to start her life here. But she was fortunate enough to meet a doctor who was able to diagnose her. So sometimes I say that like this book started when I was 6 because I was interpreting between my auntie and nurses and doctors. But yeah, I grew up knowing about it, thinking that it was a very rare disease. I did not understand the difference between something being rare and something being neglected, you know, where we have like 6 million people, Chagas disease, all of them Latinx for the most part, but it's been ignored for so long. And so it was only, so my auntie was in that chronic phase that Dr. Marcus was just describing. So she spent about 30 years like in and out of hospitals, in and out of emergency rooms, sometimes spending months in the hospital, because there isn't a cure once you're in that chronic stage. And so it was with managing symptoms. And in her case, the parasite was actually attacking the gastrointestinal system. And then ultimately, of course, her heart gave out in that kind of battle.
And so Rachel, it's actually kind of rare from what I understand too, that an American doctor would know so much about Chagas. So I'm really curious as to how you became aware and how you really came to dedicate so much of your career to it.
So you're absolutely right. And I learned about it in the way that most people do if they're a medical student in the United States medical system, which is that you learn about it in your parasitology class and people describe it and then say, you'll never see this because it's only in Latin America, which of course ignores the fact that there has been such a huge population shift out of Latin American countries to the United States. I had always really been very interested in parasitic disease, and I actually had always thought that I would end up working in Latin America. I just really had working with the Latin American community and thought it would be just really gratifying to live in a Latin American country. And then ended up not doing that. And then at some point, I actually reached out to a real luminary in the global health world, Peter Hotez, who is also very interested in Chagas disease, and asked him, was really having a career crisis moment. And he said, there is a very large community of Bolivian immigrants who live in Northern Virginia. You should keep your day job as a cardiologist because you're going to need that money, but you should set up a Chagas disease clinic for them. And I had been to Latin America to learn about it before. I've been to Brazil and to Argentina, but I never really thought that I could do that kind of work domestically. And lo and behold, I was living across the Potomac River from a group of people who have the highest risk for Chagas disease of any group of individuals in the country. So that's how it started back in 2012, I think.
Okay, so far we've talked a lot about sort of the disease, and it can maybe seem like the kissing bug is very much about the disease, but I do want to talk about your Thea, Daisy, because I think that one of the most engaging things is kind of the story around how you did become interested. So let's talk about Thea. One of the things I love so much about it was how you just never really shy away from the difficulties that you have with her, and how, along with informing the public, a lot of this book is a coming of age. And so why did you decide to take that approach?
Because I had a wonderful editor, actually. I was not planning to write about my auntie. I actually expected that my auntie would be maybe a page in the book at the beginning of the book to explain why I was writing a whole book about Chagas disease. And then this wonderful editor said, well, would you be interested in writing a little bit more, adding a little bit more memoir? And I said, of course I would. I just didn't think anyone would be interested necessarily in our relationship and all of that. And then a little bit became, like the whole first third of the book, and then extended further in. And I realized, part of why it appealed to me when she asked me, by the time I worked with an editor, there was already a lot of reporting that I had done. I had already probably at that point been doing interviews for about 3 or 4 years. And so something that I had that was, very clearly happening, of course, is that I was I would learn something about Chagas disease and think about my auntie, because we never knew another family with Chagas disease when she was alive. We never did any research. We never read anything. And so while I was in the process of my own journey of learning so much more and also meeting families with Chagas disease, I would just, my auntie was always there. She was very much like, just felt like she was very much with me in the sense, at least she was on my mind, in the sense of like, I would meet a patient and think, oh gosh, my auntie would love to talk to this person, So I think the sense of, it's strange because I think in part, I started working on this book as a way to escape the grief. And then I think like I ended up going more deeply into it unexpectedly because of course, like she was always coming up in my mind. So when the editor asked, I was like, yeah, I think I probably have something to say. And then it extended, and I think it's worked well for readers. You know, I feel like there are some readers who hear, okay, there's a nonfiction book about a disease I haven't heard about, and they're really interested in the medicine and the science. But then there are many readers who are like much more interested in the kind of mother-daughter relationship that we had. And the fact that, like, you know, we didn't have a perfect relationship. We had a very imperfect, difficult relationship. And those are some of the stories that you don't hear about around grief, you know, like it's much, I think, more common to hear about grieving someone that you had a really loving, beautiful relationship with, and you're just like in the loss. But like one of my central questions did become like, why am I grieving her? You know, she didn't talk to me for 7 years. There was so much about my life she didn't approve of. She didn't want to have a niece who was queer identified or political in any way. You know, she wanted an obedient child in so many ways. So yeah, I don't know, something like, I think it was like, for me, it actually ended up being so helpful to explore, like, yeah, what does it mean to grieve someone that you had such a hard relationship with? And why don't we talk about that more often?
So I also saw her inclusion as being, because she was such a complex person and your relationship was so complex. And yet on the other side, the way that doctors kind of treat women and the way that, you know, when we're talking, how we talk about Chagas, you know, there's sort of like these sort of implied metaphors. I think about like, you know, how it's called the kissing disease, how it's called, how when we ask like, how did Theodora even get sick? It's because she bit this apple, right? And she got sick. And there was a bicho in there, which is slang for a bug, but also for a penis. And her symptoms were digestive. So she had a big hard stomach. So people thought she was pregnant, even though she knew she couldn't be. They didn't believe her. So, you know, I felt like there was a dichotomy really between like a good girl, bad girl, which kind of like played out in your relationship with her. But how do you see that playing out kind of in the medical community, or do you see that playing out?
Oh, that's a really great question. Yeah, I think that I think like what stood out to me when I was interviewing specifically patients was actually the part around you know, not being able to easily find doctors who knew about the disease. And so, like one patient that I interviewed, she was connected with a doctor who it sounded like it was an infectious disease specialist. I didn't get to interview him, but he didn't seem overly worried. So she thought to herself, well, this can't be serious because he's not worried about it. And this is back in the 90s. And then other people that I interviewed who, like this one woman really stands out to me who, she had been diagnosed with Chagas in her own country. And when she was giving birth here in the US, you know, on the forms, when they ask you about, you know, your medical history, she would always write down that she had Chagas disease. She's like, no one ever asked me. Like sometimes one person would be like, what is that? And she's like, I don't know. I was diagnosed in my home country in Bolivia. And I don't, you know, like, what do I know? I know less than you know, right? And so that there was definitely like just such painful interactions, you know, where there was like, it was painful because there was so much like neglect around it and so much, you know, just the lack of awareness. And patients look to their medical providers, you know, including like nurses, anyone they interact with in a medical establishment, to kind of cue them about how serious is this. Yeah, does that make? I don't know if that makes sense.
Yeah, I guess I kind of see like they're kind of like looking for answers and how the affect of like these doctors, and they're not really.
Yeah, they're not always receiving they're definitely not receiving. So as a journalist, it put me in a really strange situation because sometimes when I was interviewing patients and their families, like I knew more about the disease than they even did at that point, even though they were sometimes in connections with doctors. And sometimes it was that they also didn't necessarily, you know, just because you have a connection with a doctor, even a doctor who does know about the disease, it doesn't necessarily mean that you have the agency to ask questions or the comfort level to ask a question, you know. And so when I was working on the book, I thought a lot about, you know, definitely about my auntie and other women in my family who, you know, when they walk into a medical office, don't necessarily feel empowered to ask questions, or and are like, they're afraid, they see anyone, with a lab coat or medical coat to be somebody who has authority, and that you have to be silent with them. So kind of going back to that question too around gender and like the good girl, bad girl, and obedience, there's always sort of going to be a tendency towards that good girl. And of course, in the Latinx community, I mean, generalization that I feel like I can make is like, we value humility as well, right? So especially if you're interacting with somebody who's a medical professional, there's always a deference to them, in general. Yeah.
Do you see that playing out in your practice, Rachel?
Well, I'm not sure necessarily I see it playing out in my practice specifically to Chagas disease, but as a cardiologist and a cardiologist who reads about the way that women are underdiagnosed and come later to medical attention because people don't take their symptoms as seriously, I'm certainly very aware of that interplay. I think one of the things that I have some chagrin about is feeling like I've tried to explain something very well, and I take a lot of time only to find out that I didn't explain it well when what the person does who's left the interaction with me isn't actually what I thought we'd agreed to do, and that I haven't explained it well, or they haven't felt comfortable to ask the questions. And you never know for sure exactly what, where the communication broke down. But I try to pride myself as somebody who does be very careful and explain a lot of things and provide written material, and still sometimes the connection doesn't actually get through.
Okay, so that kind of takes me back to the idea of like the coming of age, because as you talk about what happened to your Thea, we kind of start with, how the medical infrastructure in the United States was in the 70s and 80s, and we kind of see how it is now. So we start with Theodora. She's actually able to get medical care as an undocumented person. And, like the descriptions of the care that she was able to get is very different than what I'm familiar with as somebody who, was more coming of age in the 90s. And so can you tell us a little bit about some of those distinctions that you may have witnessed?
Yeah, I mean, it was a very different landscape for immigrants in 1980. I think people even forget that we were able to pass an amnesty law in the 1980s. So if you don't know about that, newsflash, we were able to pass an amnesty law. And I mentioned that because I had relatives who were able to get their status legalized in the US as a result of that amnesty law. I had my boyfriend at the time who came in with that amnesty law to people that had been living here for many years. So it was a very, very different landscape. But it was also, I think, the beginning of the end as well. So we don't have that reality. She was able, as I write in the book, there's no indication from any of my family members that the doctors or any of the medical staff treating her were preoccupied with her status at the time. I obviously don't know exactly, we don't have any records from when she got care, but there was just no questioning around that. And today it is really different. Today it largely is going to depend on where you live. And I think there's a lot more advocacy that you have to do for yourself, or that someone has to do on your behalf. There's a lot more just bureaucracy built in as well. That's been a consequence of the backlash to immigration in the U.S. So some of the patients that I wrote about in the book in the DC area, we're very fortunate. Like, we're able to use some of the help that has been specifically set up for immigrants. But others can't. I wrote about one patient who, she would have to still wait a little bit more because we forget that there's to qualify for Medicaid, you have to have been in the country for 5 years. And so she was able to get prenatal care because that's sort of across the country. Most places have made those exceptions for prenatal care. But once prenatal care ends, the mother is left, to figure out her own healthcare access, while the baby might be covered under CHIP. And of course, all of that also depends largely on where you live. Dr. Marcus, I don't know if you wanted to add something to that, to access to care.
I think that's a really great summary of the situation, but it's really very frustrating. And if you work in the area where I work, you're dealing with 3 different states worth of programs, and sometimes it's county by county. So, you know, I might have somebody who lives in one county in Maryland who is eligible to get care through some specific program for that county, but if they live across the county line, they don't, which means that sometimes we're even faced with trying to, you know, consider telling someone to move to some place where they might actually be eligible for more munificent healthcare programming. So, and it is why it's very difficult to come up with a sort of national policy decision, because so much of it is by state. So our colleagues, you know, that Daisy and I worked with, who work in Massachusetts, have a much easier time with some of these issues because there's universal healthcare there, and here it's just not the case. And then also at some level, even if you have healthcare, I would imagine most of us are very familiar with the deductible, and many of my patients are living with such low financial means that even what many of us might consider to be a fairly trivial amount of money that they're asked to pay is actually really not something that they can support. So,
And I'm sure
glad that you also. Sorry,
oh, I'm sorry.
I was just going to say, I'm so glad that that she mentioned the counties, because when I was in Texas, that it really stood out to me. This cardiologist who was like, the county level, we fought to have defibrillators basically included and covered by local Medicaid programs, but they had to really fight for that. And so she had a patient who would have been, she felt, a good candidate for a heart transplant. And unfortunately, that's where the point that she was at in terms of having Chagas disease is that the defibrillator was no longer, giving, you know, there was going to be limited time, but this person was not going to be covered, under their local Medicaid for a heart transplant. So yeah, the county, and that was their count. So it was this painful situation where actually the county actually had offered more care, but there was this limit up to which they would go. Yeah.
So it sounds like we're really talking around an issue that's brought up in the book, and that is this idea that there are 2 Americas, right? Mm-hmm. Can you maybe tell us about that?
Yeah, it's what I write about in the book is actually a phrase that Dr. Paul Farmer used, and people might be familiar with him. He passed away, I guess, just recently, but he dedicated his life to global healthcare, and specifically Haiti, but also in a much larger way too. And I was really struck by something that he was quoted as saying in his biography, which is that there's a great epidemiological divide. And so on one side, people will die of sort of chronic long-term diseases, and then on one side of that epidemiological divide, and then on the other side, people die because they can't get access to healthcare, they can't get access to treatment, or aren't diagnosed. And that when I read that, it crystallized. You know, as a writer, you're interviewing and you're researching and you've got your notes, but you're also looking for images and something that would clarify everything. And when I read that I just got this really strong image of like a map, you know, with a line drawn down the middle. And that was a moment when I read that just clarified, like, yeah, we won't actually eradicating these diseases. Like many of us, I write about in the book, many of us don't think about tuberculosis, but in certain immigrant communities in the US, you do. In many parts of the world, you still think about TB. If you spend time in homeless shelters in the prison system in the US, you're going to think about TB as well. So we haven't quite eradicated it, right? We've just contained it to a certain part of our country. And I, you know, in the book, it really also came into focus for me when I was actually in a church basement following what Dr. Marcus and her colleagues were doing, which was community screening. So going into the community to offering the option of seeing, you know, how widespread Chagas might be there, and helping to connect people with medical resources. And, you know, I think for me, you know, standing there, you know, talking to people and just having that moment when I looked around and realized here we are in a church basement on a Sunday, and, most of the United States won't see these people. Like, this is not something that most people even know. I'm sure most people in Virginia didn't even know that that was happening in a church basement in Virginia. And that was also that moment of like, oh yeah, we have two countries within, our own borders in terms of when we're looking at public health.
Right. And I definitely want to come back to that church basement, but the idea about the two countries and it seems like you were even talking about that a little bit, Rachel, when you were talking about the different counties and the different, how you have to like kind of maneuver with these policies from state to state.
Well, I think that it's a very accurate description of the state of our healthcare system right now. I mean, what people are able to obtain if they are well insured, have employer-based insurance, but it's also I think we have to add in for this particular community. There's many people are not proficient in English, so it's very difficult for them to advocate for themselves. And there's a certain subset of the community that would prefer to stay off of the radar screen, because the radar screen is a scary place if somebody's trying to deport you when you show up on it. So there's that whole additional layer, I think, for diseases of immigrants even. I mean, there's diseases of poor, and then there's diseases of immigrants, particularly people whose legal status in the country is not clear. So I just add that into the issues that we face with working with this particular patient population.
So I do want to go back to those basements. One of the things I know that you hear in some of those basements are these kinds of attitudes around, I don't need to worry about this. We know that we're all in God's hands. God will take care of us. When you hear that, how do you respond?
Well, that's the benefit of being a journalist. You don't have to respond. You write it down in the moment, right? Because I'm not there in an advocacy role or anything else, right? So for me, it was very familiar. So it made sense that answer came up. We were in a church basement specifically, right? So these are people who not only were they in church, but some of them had actually driven like 40 minutes or even longer to actually worship with people from their own home community as well, meaning from particular countries in South America. And so it made sense. But for me, it was also really familiar, from my own family, because, when you have very few resources, like when my auntie was diagnosed in 1980, at first, my mother thought that we were going to have to pay for her medical care. And so my mother had a whole plan, like she was going to go on the local radio station in Spanish and ask people to send us donations. And like, it breaks my heart, when I think about it, that like my mother thought we could get that much money in donations, that she had no idea like how much money, these surgeries would cost, that it would be like impossible. But when you have few resources, like, you do turn to like spiritual traditions, and like your faith to like carry you through something. And a lot of the people that I was interviewing that particular day, and also other times, we're also talking about, their experience of healthcare in South America and Central America and Mexico, which is also really familiar to me from my parents, which is like, if you don't have the money, you're not going to get treatment, you're not going to get care. And of course, that also really varies depending on where you are. But in general, I remember like someone I interviewed who had Chagas disease, and his auntie had also had it. It's like, when you get the diagnosis, you start saving up money so you can pay for a pacemaker. So it's also a very different way of thinking about healthcare compared to people who grew up in the US with their parents having health insurance, with like I look at I teach at the college level. And so I look at the majority of my students grew up with their parents having health insurance, and they're expecting, I'm graduating this year. Like I have a bunch of seniors that are going to be graduating in a few weeks, and they're expecting to get a job that comes with healthcare, And so, so for my readers, I think for many readers, I wanted to underscore that, because I think we forget that that's not the standard expectation that people have. And so you do lean into your faith.
Mm-hmm, mm-hmm. And how about for you, Rachel? How do you handle that attitude?
So that's a really great question. I think one of the things that we tried to do was to set ourselves up for success by asking for the pastor or the priest to be an advocate, because the clergy are such powerful members of the community and so trusted that if they will vouch for the program and the need for testing, then people are more likely to do it. So I think and when you host something in the church, I think people already are very familiar with that environment. It's their environment. We brought it to them. So I think they'll then feel more comfortable. And also to, I mean, there's someone that Daisy knows well and is really a role model for all of us in the Chagas disease community in the US, is Shiva Maimandi, who's really the cardiologist in the country who first started really thinking about the magnitude of the Chagas disease problem here. And her program works so well because she has promotadoras who interface with the community too, because I'm very aware that I'm a physician, but also I'm a gringa, and so I know that it's important for me to have sort of the backup of people who are part of the communities. But I think often that comes that can also come from a face of fear and sometimes denial, and it's cousin in this setting is worry about the stigma of having the disease. And so people really don't want to know because they're worried about what it then projects to other people around them. I mean, in particular, I think Daisy and I both know someone who has the disease who is a strong advocate for testing, but doesn't want to ever be named or in photographs because she's worried about the stigma that would arise to her children who have, or one child has the disease. So in any event, we do try to work with that and try to then come up with all the reasons why you would want to know. And one thing that tends to be pretty effective is that women are always so concerned about the health of their children. So for a woman, it's pretty easy to say, one reason you might want to know is because the disease can be transmitted from mother to child. And if you have the disease, then your children should be screened so we can make sure that they're okay. And that gets people sometimes. And then it's pretty clear from the literature that if someone in the United States has the disease, that their friends and family, particularly family that grew up in a similar environment, are at considerably higher risk for having the disease. So, that's how I try to promote it. But there's some people who just would prefer not to know. And then that's just where we are.
I really want to go back to what you said about stigma, because it's reminding me of a particular woman in Texas who was infected in her Texas neighborhood, right? Like, this is not actually just a Latin American illness.
Yeah.
And she asked her doctor, well, shouldn't I tell my neighbors? And the doctor said, do you want to be Typhoid Mary? And I learned a lot about Typhoid Mary that I didn't know before. So I was really surprised to hear that there's a stigma to Chagas. So could you maybe unpack some of that for us?
So in the Latin American countries where it's highly endemic, it was a marker of having lived in rural poverty. And so that, I think, was the big stigma, so much so that there actually had to be laws in some countries prohibiting discrimination against people who had Chagas disease, some of which was economic, because unfortunately some of the people who got the disease actually were prone to actually dying suddenly in prime working years. And so there was a reason to discriminate because you didn't want your workforce dying. But also I think there's a sense that it marks you as somebody who is poor, because unlike the situation here in the United States, if you live in the kind of housing in which these bugs live that transmit the disease, they're like they're like the cockroach infestations that we have in the United States. I mean, there are thousands of these bugs. These are walls that are not plastered. These are houses that have pomfron roofs, may not even really have much in the way of walls. Domestic animals walking in and out of the house. I mean, so it marks you as being someone from. So if you're maybe a more urban elite, then you look down on people who have these diseases that are associated with that kind of housing. And
so
yeah.
Sorry.
No, go ahead.
So you're saying that even in this, it seemed like a white Texas sort of suburb. Maybe it wasn't an upper middle class suburb, but even in that setting, that sort of stigma would still exist.
I don't know, Daisy, I don't know what you think about it. I mean, I think, you know, if I'm surprised that anybody thinks that anyone would know enough about Chagas disease to have that be stigmatizing. I mean, in fact, most people don't know. So particularly people, I imagine this woman, I know who you're talking about, I think, and that this person comes into contact with, are unlikely to know about it. If they decided to read about it, though, you know, the whole process, as Daisy describes well in her book, is it's not all that, you know, it's unsavory. So maybe there's that, but, you know, or maybe it's that it's a parasitic disease, or it's a disease associated with poverty. So, but, you know, I don't work with I work with Latin American immigrants in general, so I don't have that much of a connection to what it would feel like to be someone.
Yeah, I mean, what really struck me in that situation, maybe Daisy, you're the one to speak to this, was that it was the doctor who was telling her, don't tell other people. And we do know that if you get treatment earlier, you know, you can stop all these like, you know, the heart issues. You don't pass it on to your babies. You won't have the digestive problems. So I was just very concerned with his, you know, you don't want to be typhoid Mary.
Yeah, in the acute stage of the disease, you can do some interventions that will that can be very, very effective. It was very unusual. That's part of why I wanted to write about it, is that it's not what we expect of our medical professionals or how to respond. I didn't interview enough patients who have contracted this parasite in the US to be able to say, you know, how widespread of a stigma it is. It was so unusual. Like, it's still very rare. The CDC has still documented, last time I checked, fewer than 100 people who've been infected in the US, because we have these wonderful kissing bugs, and, you know, all in the Americas as well, mostly in the South, Southwest, Texas, all over California as well, Northern and Southern California. But I didn't interview enough people to say how much of a stigma. I think that it was largely this unknown, and this, you know, this sense of just the combination of something that is not known and that is under the umbrella of infectious diseases, you know, I think does call back to just calls up fear, you know, and strangers. And we, you know, as Dr. Marcus was saying about, you know, stigma within Latin America, there's just across the board historically been stigma whenever there's a disease that people don't know, don't understand. The wonderful and kind of amazing part about her story, and part of why I wanted to include it, is that that particular patient, about a year later, as she was talking about it with a friend who was a nurse, decided, like, I should be talking to people about this. This is ridiculous, you know. And she did, and it took a lot of courage, because people in her community, you know, people like, you know, in her social circle were not always, you know, had reactions like disgust, like aversion, like, oh, you have parasites, like what, you know, and you know, to her credit, like, she learned more about her disease, and she, like, was able to explain it, and she's been on panels. She testified at the FDA, you know, as part of, like, trying to get treatments in the US approved. I mean, she stepped up and did, like, a lot that not everyone else would do. Some of the reason I wasn't able to interview other patients is that they refused to talk to the media, actually, you know. So I did know of doctors who had patients and they just refused to talk to me. And, you know, I don't know if that, you know, to what degree it was stigma, to what degree it was I think it's shocking, you know, I think it's shocking to be an adult and be told, like, you have this disease, you might, you know, it's around sort of 1 in 3 people who go on to develop cardiac complications, but you don't know if you're going to be one of those 1 in 3. So I think it can also come, like, I know for this particular patient, it was very shocking just to get the diagnosis. She'd never heard of it. It was very scary initially. So there's a lot of emotions that people have to work through, I think.
And they do tend to think of it as this disease that only happens in Latin America. I do want to remind people who may be viewing to please submit your questions whenever you think of them, and we'll get to those at the end if there's any questions. So, okay. Now, one of the things that, again, with talking about the Chagas and how many people may have it, there was a lot of moments in the book where it did kind of seem to me like the current numbers of how many people do have Chagas right now might be an undercount. What do you think about that? Either of you?
I think, but almost by definition, it is, because nowhere has done, either here in the United States or abroad, has actually done the requisite testing to really be able to say what an accurate count is. There's no nationwide sort of surveys that are done. Most of the data from Latin America comes out of blood banking, and the people who donate blood are not necessarily representative of the population at large. So, and that's in the United States, there just hasn't been funding for those kinds of efforts. So you see pockets of information, like the information that Shiva and the Andes group provided out of California, large scale survey out of Boston. This study that we did, that was actually run by Yahaira Castro at Johns Hopkins. But it's nowhere near a nationwide analysis. So the estimates that we have in the country right now are based on the estimates from the countries of origin for the immigrants. But if we acknowledge that those rates are suspect, then basically you end up just really not knowing for sure. So the estimates that we have are, and then there's also the issue of how we actually accurately assess the population of immigrants who are at risk, given the fact that there is a certain proportion that are undocumented, and how do you know how to deal with those numbers. But we have to come up with something. So I applaud the efforts of the groups that actually went out to come up with the numbers, but I think we really don't know for sure. And my guess is that they are modestly higher than what's been quoted.
I think at this point the Los Angeles numbers are where someone actually went out into the community and was screening is probably the biggest study that we have.
Boston now has about 8,000, so they have.
Oh, excellent. Okay.
Yeah, so they haven't published that yet. So the series.
Oh.
But,
I do have a comment here, and I think this is something I just want to. This is from it's from our chat. I think it is important to talk about passing the disease through pregnancy. Mothers who may have the disease and maybe not know yet can pass Chagas on to the infant. I believe Dr. Marcus has been able to set up screenings for newborns in Virginia, and of course, you did talk about this in the book, but yeah, maybe speak about that now.
Well, so COVID has delayed our start for this project, but there is a really wonderful prenatal clinic that provides care for a large group of women who are at risk for Chagas disease. And as soon as some of our COVID obstacles are over, they're going to begin screening the probably 4,000 women per year who are at risk. And it is really important to do because the baby then is at risk for, if the mom has the disease, for developing congenital Chagas disease, and the baby is probably in the best position to be treated for cure. And then once mom is done with breastfeeding, mom can be treated to prevent passing it to any future children. And then of course all of the other children of that mom would be tested. So it's really a very cost-effective way of looking for a whole bunch of people who might have Chagas disease, and really just so critically important because there's such a high probability of cure if you treat the baby right when they're born. Mm-hmm. So we're really excited about it, but it hasn't actually started yet because of COVID.
And that COVID. We have another question.
So glad. I'm so glad that someone brought that up in the chat, because that was one of the most shocking experience for me learning about congenital Chagas. I didn't know it existed. My auntie didn't have children of her own, and so it was a surprise. And also, when I was reading one particular patient, she was also shocked, because very similar to me, like the concept of Chagas disease was something that happened to older people, to adults. Oh, it's telling me my internet connection is unstable. Interrupt if you can't hear me. But I realized I had that conception as well, that this was something that happened to adults. And it makes sense because the parasite can be dormant in the body for many years, and in some cases even up to 3 decades. And so when you're seeing illness is actually in adults. there was an Argentinian doctor who said, like, he really wants people to think about Chagas as a pediatric illness, because it can be interrupted during childhood and not progress. So thinking about, like, yeah, we have a lot of Latin US that could be getting screened. So this is an exciting possibility in Virginia.
I do have one more question here that I want to try to squeeze in. It's from Sarita Gonzalez. She says, thank you for highlighting this disease and the inherent racism in the medical community. Congrats on your Penn Award. What has been the biggest surprise now? What has been the biggest surprise now the book has been published? That's one. And what are you working on next? And will it also be a journalistic approach? So 2 questions.
Hi, Sarita. So good to see you, or not see you, but no, you're there and not online. I think that the biggest surprise for me is, it's very strange to publish a book. You work on a book for many years, you don't know who will read it. Who will pick it up. So I was hoping that medical professionals would be interested in it, to raise awareness there. Like, that was probably, one of my biggest hopes. And so I was just with a book the other day, a group of nurses and pediatrics in Kansas City, of all places, who found the book and wanted to talk with me about it. That's like been a huge surprise. I'm going to be talking, actually a really big surprise too, is I'm sort of like a full circle. I'm be talking with some medical students at Columbia University, and that's where my auntie was treated, or was part of that medical institution. And so that has been really surprising, just to have medical professionals be interested in talking with me further about the book has been really amazing. And just to have it get on their radar, and to have people who have gone through medical school, and, like, as Dr. Marcus was saying before, either maybe heard a passing reference to it or didn't hear about it at all, be interested and curious and learning more from somebody who's not, I'm not a doctor. So they're learning about it through a kind of, journalist perspective. And yes, I'm working on a new book. I became really interested in how we think about citizenship as a result of working on this book, because I started to really think about, well, how did we handle medical care when our country was just beginning? I mean, the idea of citizenship is always in flux, it's always changing, but what did medical care look like at that time when we hadn't quite decided yet about citizenship exactly? So that's like one piece of many. There's also like a piece about the rapper Cardi B in there. So it's going to be a wide-ranging nonfiction book.
Okay, I do have to wrap it up here, but before we do, I just want to ask one last question, and that is, can you offer any resources for people who right now maybe have Chagas and aren't getting the best care, or people who think they're worried they might have it?
So that's really one of the main missions of our nonprofit, is to try to facilitate care and testing for people. So we have a website, and then I also will put my email in the chat for people, just because unfortunately the website's new and it's beautiful, but if you put a comment into the contact us email section, it doesn't actually arrive to me, so I can't see what you're saying. But I'm always happy to talk about Chagas disease with anyone. I particularly also like to reach out to the physicians that are caring for people who have Chagas disease, because in general they are very well-meaning but don't know much about the disease. And then I am happy to help troubleshoot how to get tested, which can be complicated. But I do spend a lot of time talking to medical audiences to try and raise awareness and to facilitate their ability to care for people who have this illness.
So I think that is a great takeaway. If you are somebody who treats people, please maybe contact Dr. Rachel and try to get more information about this. But it is about time, I think, for us to wrap it up here. I just want to thank Daisy and Rachel for joining us today, and also all of you at home. I hope you consider buying the book. It's the Kissing Bug. Please consider buying it from your local bookseller or through the links in the chat. And you can explore upcoming virtual events from the Virginia Festival of the Book at vabook.org. Thank you so much for joining us.
Thank you, Leah.
Thank you for having us.